so full of carbohydrates and not quite enough fibre and all these kind of public health things that we might talk a little bit about today. And it's just great that so many people have been able to come. We've got some Manchester University biomedical students here, which is fantastic. We've got Sarah from the Portman Group. We've got a lot of supporters of the CSJ present and people who we've had a long-standing relationship with. It's absolutely fantastic to be working with Noreen again, and thank you so much to Back O'Connor for sponsoring the event. I'm Samantha Callan. I work with the Centre for Social Justice on all their families and mental health issues, and although the title of the event, Healers Not Dealers, you might be thinking this is all going to be about addiction. This issue touches so many areas of social policy. And one of the clearest messages that the Centre for Social Justice has articulated really since its foundation is the need to move beyond treating addiction and other social problems through drug substitution, through medication alone, and frankly to have a higher ambition for people who are trapped in a downwards pernicious spiral of addiction and poverty too often. I think we're touching really, and it's great to have Chris with us, a GP, we're touching it on a key debate in medicine and social policy, whether we lean towards kind of more biomedical means of treating problems, or whether it's psychosocial, and is there a good, is there a bad? I mean, we looked at mental health in a lot of depth. It's not as simple as medicine or therapy. What we found was that 2/3 of the burden of mental ill health rather, is not reduced by treatment per se, whether that's drugs, whether that's therapy. So it's not quite as simple as saying it's either or, as I'm sure all of you know and the panel's going to discuss. We've got a fantastic, in international terms, therapies program called Improving Access to Psychological Therapies. But what we found in that program is that it's far too narrow, the kind of therapies that people can have access to. So as I say, when we think about therapy versus medication, it's not a simple dichotomy. We've got to think harder about this. But I've touched on mental health. Let me just touch a bit more on the kind of medication side, the addiction side. A few statistics to whet your appetite, and then I'm going to introduce each member of the panel one at a time, because if I don't, then by the time I eventually get to Chris, you'll have forgotten how wonderful he is. If that were possible. Just a few stats, as I say. The number of prescribed antidepressants has risen by 50% in 6 years. There are 1 million long-term prescribed Valium users. Something of real concern to me as a parent. We've had a quadrupling of Ritalin or Ritalin-type drug scripts since 2000. With Noreen's work, I mean, she'll probably touch on these herself. I'm just going to finish with a few more on addiction. When you look at what works for addicts, turning their lives around, residential rehab, helping people kind of become completely drug-free, not just having a substitute, only 2% receive residential rehabilitation, similar to what Noreen offers. And yet, so concerningly, in Scotland, where I come from, methadone, which is a very common substitute, is associated in 47% of all drug-related deaths. We can't just say, cut crying, get them onto methadone, we're on the right road. No, these are people's lives we're talking about. And really, this is not, again, bad Labour government, fantastic Conservative government. We've seen a 40% rise since the coalition entered office on substitute prescriptions like methadone. People who've been on substitute prescriptions for 10 years. This is not just a bridging, a kind of a road to something better. This is often where people are stuck. So something we, as I say, we've been thinking about for a long time is how can we help people escape that addiction, frankly. So I'm going to start with David, who it's an amazing panel we've got today, frankly, because we've got a former co-chair of the Addictions Working Group from 2006-2007, when we were doing the really seminal work in the Social Justice Policy Group before the last election. And David was very involved in that. So in some ways I feel he needs no introduction, but I will just very briefly touch on the fact that He's been Conservative Member of Parliament for Enfield Southgate since 2005. He's been Shadow Justice Minister. He's chaired the Addiction Committee, I've already talked about that, Addiction Committee of our very own review. And he's been PPS to Francis Maud. And he's now PPS to Owen Paterson, so somebody who really is getting into a lot of important agendas. But I would just say before he starts to speak, I know of David that he has a real reputation for honesty and integrity among MPs, and when he gets up to talk, people have got to listen for that reason, if nothing else. Thank you.
Thank you very much. Thank you. That's very kind. I may not actually get up to talk, just only for a physical reason that I think we were cracked a rib trying to beat the press lobby at football yesterday. But what it did lead to is that, I don't think I'd have experienced this, is that I got drugs from the CSJ today. That's paracetamol just to get me through. But it's great to be here, and pay tribute to the Centre for Justice and BAC Congress sponsoring this event, because both who very much in this for the long term, and I know I'm talking amongst a number of experts here, and I'm very conscious of that when talking about the subject. But I suppose over the years I've got to know the subject fairly well. It started off very much professionally as a criminal defence solicitor, seeing my filing cabinets full of people recycling, sadly, through in the criminal justice system, and predominantly addicted to drugs and alcohol. And one of the areas that I wanted to resolve to focus on more relentlessly was the area of drugs and alcohol, and I think I've probably done that over the years. One of the things, though, just to talk positively about the coalition government is that I've been involved and continue to be involved advising Oliver Letwin in terms of drugs and alcohol policy. Amongst all the concerns and priorities for the coalition government, of which Oliver Letwin has been integral to seeing the implementation of. And he's got a whiteboard, a famous whiteboard, which only he can read with his handwriting. But very much in the centre of that has been the whole area of drugs and alcohol, literally trying to, from his own passionate concern, as well as recognising practically the immense impact on the individual and the family, community, and beyond, and obviously financially as well. And so that was impressive, and I've been involved with him with the whole area of trying to roll out drugs and alcohol recovery pilots and really up our game in terms of recovery. Because it's great to talk, a lot of conferences about economic recovery, but we talk about social recovery, and this is what we need to be continuing for. And I do think there is a context, because whilst I don't want to naively suggest that I've got the silver bullet in all this, and that we should just say that one side was bad, one side was good. There's not. There was a whole lot of investment from the previous government in relation to drugs and alcohol, but there was a diminished ambition for people to move them into recovery, and almost a fatalistic approach in some areas to just condemning people to the idea of a chronic relapsing condition. But what I'd like to focus on, and others who can debate, the experts to talk about relapsing, is chronic. And no one could be in any doubt that we inherited a chronic situation. Oh yes, investment, oh yes, a whole lot of improvements in quality and public health outcomes, and I don't want to argue against, in certain areas, the value of a maintenance programme for people to get safe and to get in a position where they may not be the clients that I used to represent so much, their drug spending may be well reduced. But in terms of the quality of life, ambitions were too limited, to the extent that, and the reality still is that if you add up the amount of methadone people are taking and say Subutex, then the estimates come to me that that's for 200,000 doses a day, 73 million doses a year. Now that's huge, and what it's led to, predominantly the outcome is less of a quality of life, few that are becoming drug-free, and a whole lot of costs that if you mountain as increase we need to do is not focus on the drug itself, but on the impact around, and that's where the answers are as well, and the experts around me in terms of that, is in terms of just the financial costs, is why it's not surprising in many ways that the government are concerned about the costs that link into economic recovery, as well as could equate some £50,000 or so in terms of lack of employability and other cost of someone who is on a maintenance programme. And that's not just 1 year. And I'd like to really focus on what the impact of that is, because for some it does lead to death, and we don't make a headline of it. So when statistics come out in terms of drug-related death from drug poisoning and the rest of it, the headlines come about the 20 or 30 or so that diabetic, that gets the headlines, that gets the tabloids, and then we look at legal highs and the rest of it. But what doesn't get the headlines is the fact that persistently high are the levels of death related from methadone. And the reality is that, yes, we've seen a reduction in terms of heroin-related deaths, and that's gone down from 2008, 897 to 2012, 579. But in terms of methadone, it was 378 in 2008, and the latest figure is 414, stubbornly high. So one shouldn't be in any doubt, and that is, there are ages, there are young people who are dying of this. In fact, there's also children dying of this as well. There's headlines as well. So let's not be in doubt that we can't be satisfied, and we can't simply, in a sense, tolerate the situation. But where I'd like to take you on is in terms of the tale of two Oxfords. One Oxford, and this is historical because there's been changes over time, but when I went with other ministers to look at various areas in terms of piloting the drug recovery pilots, we took ministers to Oxford, and there we heard about shared care. Now, shared care, sadly for many areas, is a misnomer, because one, it's not shared, and it's not much care. And the lack of shared is that, and we heard this, and Oxford themselves, those providers involved in that would themselves accept that, too often the case is that the contact we spoke to addicts themselves, their contact with the health service was with a nurse prescribing them the latest script. And these were people 10 years, 20 years, they were geri addicts, who had had no structured intervention at all during their period of time. And they, there will be different, there were people who managed to get into other forms of structured treatment. But that was their experience of shared care. There was no shared, and the care, I think, was very limited. And that shocked many ministers, and they wanted to do much more about that. And that isn't exclusive to Oxford, but other areas as well. And we must do that, and I think the government have been trying to do that, and we can talk about success or failure of that. And we need to look at how we can sustain a recovery that goes beyond simply relying upon and focusing on the particular drug, but also relying upon and just accepting simply a substitute program. We want to go away from what was almost a tick box mentality of just simply saying that's good enough for us in terms of being in treatment. We want to look more about the outcomes and the sustainable outcomes. And so the other Oxford, for example, is obviously the Maryland Oxford of Oxford House. There was the Oxford House in 1975. More coming over here, and we see other concepts of it. Peer-led support, recovery that is sustainable, that is there through the recovery champions and others who are really leading, containing and building that recovery community that we talk more about. And there you see great results. And you see people helping themselves to support each other. The hidden army of recovery champions, the anonymous groups AA and NA, that are much more embedded and entrenched in terms of policy solutions. Moving on to that, we see how that's very much embedded. You see in some areas that that's embedded through really great leaders, and we'll probably hear from one another about that. But you hear in other countries much more embedded with the mainstream of the public health service, of ways that we can, yes, have those interventions, say alcohol, or the more specific interventions in terms of drugs, but ensure that that is very much linked in, even maybe being conditioned, linked in to the anonymous groups, because more often than not, statistically, and evidence tells us that sustainable recovery is linked very much into those groups. Yes, peer-led support, and yes, those recovery support groups that lead to that sustainable way. And the Oxford House movement is an example of that, because it's when there's that link with the anonymous groups that there's been that sustainable recovery. And that's what we need to be about. It is not a short-term fix, as there's no quick fix we're seeing here. It is about the long term, and we must be that much more ambitious about recovery. There has been progress in terms of the latest statistics in terms of from 2010 to 13. You could say there's been a 50% increase in terms of those opiate users becoming drug-free, and in terms of the numbers of new opiate users, there's a reduction of 15% as well. So if you work that out, that is going in the right direction. But we need to look at how we can ensure there's greater links, yes, off the drugs, but into employment, into restored relationships, and the like. And that's where our ambition needs to be, and we need to make those links to ensure that we are really going to ensure that social recovery is here to stay.
so much, David. I'm going to keep signing up because I noticed I was sitting at the back yesterday, and I noticed how you couldn't really see what was happening at the front. And if you want to, if you've also been injured with, in athletic pursuits, then do say like. It really is a pleasure to introduce Noreen. Noreen has been such a good friend to the CSJ. Noreen is currently chairing our, I'm just going to grab this for a second, our addictions working group. And they've recently produced a really comprehensive report on just what the state of the nation is, just what our kind of levels of drug and alcohol addiction are in this country. No quick fix, it's almost still hot off the press. So please do download that. I think we may have some copies, and there's certainly executive summaries. Now, the reason we love having Noreen as our chair is because she is the very opposite of a theoretician, in the sense that she knows what it is to go through alcohol addiction and to kind of claw her way back into recovery and to build an amazing life, which is the ambition we have for so many people. And when I say build an amazing life, often you only really find fulfillment if you're thinking about other people. And what Noreen has done is she's gone back to her local community, probably never left it, but she's built an organisation I'm sure you're going to describe that is at the heart of the local community. Let me just give you some of these the statistics about Back O'Connor. It's a rehab programme, as I say, at the heart of the community that employs 84 staff, so that's clinicians, resettlement staff. 50% of the staff are in recovery themselves, and they've got qualifications right from NVQs through to degree level. And if you go over to the main building, there's Langan's tea room, so enabling people to learn a trade, to have to be somewhere on time, to have to serve the public. So it's actually putting tools in people's hands. Now, again, I'm very proud of Noreen because she's got the MBE, she won, let me get this right, the Daily Mirror People's Justice Award in 2006, but also what Noreen is great at doing is building coalitions. She just is not interested in polarity, she wants everyone to work together to really have a rehabilitation and recovery revolution.
Thank you.
And let's just say, wow.
I don't have an injury, just heels, just sore feet. Thank you for that very kind introduction. I said I'm the founder of the CSJ Conservative Centre, and also I'm very proud to chair one of our greatest think tanks in this country, so it's been a great pleasure doing that with CSJ. I've been asked today to talk to you about how does BAC work with medication, people on medication and therapies, and how do we integrate people back into the community. And I think just very, very quickly, it's, BAC is a partnership. BAC is based in Staffordshire, we have 2 centres, but we have huge partners. So we cannot deliver it on our own, we could never deliver it without our partners. And that is housing, that is education, right down to the Rotary Club. So the Rotary Club come in, they do role plays, interviews, we have the WI. If there is an organisation out in our community that can help provide resettlement and our clients can get independent living and contribute back to their community, then we work with them. We don't duplicate, and we do it together. So we are fortunate. We talk about GP prescribing, we talk about GPs now that are GP fund holders. We have GPs that have funded a couple of detox beds for a number of years now. So it's about evidencing that people can and do get well, and actually that recovery is contagious. So I think that before people can enter that stage, they have to be detoxed first. And in the 20 years that I've worked in the sector and having been through rehab myself, I have never ever met a drug user yet who uses one drug. I have never met a heroin user who simply just uses heroin. They use a cocktail of drugs. So it isn't as simplistic as the media and the legalisation lobby would have us believe. Actually, they come to us having been on heroin for a number of years, then been prescribed methadone, and I'm talking about high levels of methadone, so 140 mils of methadone. On top of that, they may be prescribed benzodiazepine, they may be using cannabis, huge copious amounts of alcohol, and anything else they can get into their hands, because we are talking about dependency. It's an alcoholic drinks to be in a permanent state of being drunk. An addict uses drugs to be high consciously all the time, so they are constantly chasing that hit, so you could never provide one drug. So often we have to do dual detoxes, and you can imagine what that is like, having to detox somebody off all of those drugs before we can start to deal with the issues. Drug and alcohol misuse is a social justice problem, and there is huge amounts of other issues. If you have somebody that's been institutionalised for many, many years, behaviour, may have abuse issues, relationship issues, we have to get to the root of what those issues are, and we have to deal with those issues first. So we will detox them, but getting people off the medication is the first hurdle, and that is often the stage where people will run. So they will be in detox, and you can imagine if you've been on all of that for a number of years, and you are being detoxed off that. So we cannot just do a simple medical detox. We have to provide therapies. We have recovery champions that work out in the community, but they also work in the detox unit. That's to motivate people. We have therapists that will work with them as well, to do motivational work. But also we have to change the sleep patterns, because we're awake all night and we're asleep all day. So we have to turn all of that around. So we have to mix that in with our therapies. And the issue I think that we're trying to cope with and battle with is the over-prescribing. Is society over-medicated? Well, if they're not being prescribed benzos themselves, they are buying them off the street from somebody who is being prescribed benzos. And all of the other things, and the Librium and the sleepers, anything else they can get their hands on. We now have a new drug that is hitting the prisons that is massively out there, which is pregabalin, which is given for neuropathy. It's also given for epilepsy, and users are now, the amount of prescribing of this new drug is just, walk into your GP surgery and tell them that you've got pains in your legs and you've got pins and needles, etc., in your arms, and you will get pregabalin. Break it up and you sniff it. So constantly we think as a country that the answer is in a script. It isn't. It is a huge, huge social justice. I'm very conscious that David's got this huge clock in front of me, because it's known that I can talk for England. So this clock there, how long have I got left?
Okay. At least,
so,
I will tell you, don't worry.
Okay. So for us, I think our policy would be looking at, what, not the overprescribing of our society. The answer isn't just in a script. Come on, if we want to get these people off drugs, let's start looking at all the issues that are behind it. It's not that complicated. We're already aware that we have rehabs in this country, and BAC is one of the top performing rehabs, that are achieving over 68% 12 months later. That people are drug-free, sustainable housing, and employment or education. Now, those are huge, huge figures for people that have been highly, dependent on drugs. In comparison, the figures for people becoming drug-free on methadone is 14%, and you'll find that in the No Quick Fix at the back of the room. So it isn't that complicated, but we can only build the recovery communities that David is talking about by working in partnership with those. We all have local areas where you have housing, your county councils, your borough councils, your colleges. The individuals live in that community, so they are entitled to use those services, and that's what we need to do. That's the only way we can build recovery communities. I was asked if I could make one policy recommendation, and I think David will tell you I'm always making policy recommendations, and I'm always standing on tables and sort of shouting, and that would be, let's stop over-medicating people. Let's stop, let's be more ambitious, people out there. These are our communities. Drug misuse and alcohol misuse does not just affect the individual, it affects families and it affects communities, and it has a knock-on effect in all of your lives every single day. So let's stop over-medicating people. Let's start looking at what the answer is by dealing with those issues. Let's start moving people to being more ambitious for people. And instead of handing them a script and saying, I'm going to give you a methadone script, or a Subutex script, or lots of benzos, or sleepers, what have you, actually, I think you can achieve more. I think you can do better for yourself, and let's be more ambitious as society. Because at the moment, we're making some progress, but we need to make a hell of a lot more. So if you are out there in communities, we can all work together. There's very good examples that are already doing it. And as David said, Lemon Stevens is a social enterprise. It's run by service users. They're all gaining qualifications. And there's a mobile kitchen making all those cakes every single day out back. And those guys are in recovery. These are guys that have been through the criminal justice system, have been on drugs for years and years. And that's removing the stigma, and that's saying that recovery is contagious. So that is my ambition, and that's my policy recommendation. Thank you.
Thank you, Nori. Never disappointed. It's funny, my notes, my biographical notes about Chris, I was going to say, as a young doctor, Chris worked with homeless people in Oxford. He's still a very young doctor. Surely doctors are becoming younger these days. So Chris has recently joined the Addictions Working Group for the Centre for Social Justice, and I am really thrilled that we've got a medic on the panel, so that if there's any reality checking to be done in this discussion, Chris, that is your job. And it's when you were working with homeless people that you began to be very interested in finding ways to help people move off medication, because they were, when they'd been addicted to prescription drugs, so that they could really, as Noreen's been talking about, move on with their lives. And I'd love it if you could pick up the stuff about Ritalin, because I know an awful lot of paediatricians say, well, if it's being prescribed, it must be necessary. But in those volumes, I'd be staggered. Anyway, over to you, Chris. Thank you very much. Chris Longstaff, GP.
I'm here very much as just a common or garden GP, so not a specialist. I haven't won any awards, and I'm no one's private secretary. And I want to give you a sort of realistic sort of perspective from my consulting room in South Bedfordshire. Patients that I see it's mainstream general practice, and whereas before I was working in a practice which dealt exclusively with homeless and vulnerably housed patients in Oxford, now I see some homeless patients, but also mainstream general practice. Okay. So one of the most important things that I think I've learned as a GP is that the majority of patients with problems involving addiction do not come to me labelled. They come with very different problems. So if I looked at the end of my surgery yesterday, I looked through and I'd seen about 5 people with addictions, and I looked through their notes and I went back, right back to the start, and I looked at what kind of problems they were being treated as initially. And there was one lower back pain with sciatica, there was one depression, there was one anxiety, there was one insomnia, and there was one perforated stomach ulcer. And actually these people have been treated for, all of them have been treated for some years for problems other than the real issue, which was their sort of addiction and social problems. And if you're wondering where the stomach ulcer came, that patient had been taking between 30 and 40 Nurofen plus a day for 5 years. It burnt a hole through her stomach lining, she perforated, she had to have emergency surgery, she was admitted to hospital. She made a recovery, she returned to the community, and it's only 2 years down the line from that she has mentioned to anyone, or anyone has found out that she is still taking 30 to 40 Nurofen plus. So it's really easy as a doctor, and I see GPs doing it, myself included, psychiatrists doing it, pain clinics doing it, it's happening all over the place, to see these manifestations of much bigger underlying problems as the issue itself, and it can be really easy to treat those sort of those warning signs rather than digging deeper. And it's so much harder to tackle those underlying problems. And so if I see a patient who comes in to see me and asks me for a sleeping tablet prescription, I can generate a prescription for a month's sleeping tablet, and it will take me between 20 to 30 seconds to sign the prescription, print it out, sign it, and hand it to them. Probably if I was running late, I could do that consultation within 3-4 minutes. Yeah. But to ask them what's really going on, why they need the sleeping tablet, why they're asking for it again, what is happening here, that takes so much longer and is so much more difficult. And then you get on to problems like childhood abuse, bullying in the workplace, alcohol dependency, heroin use, collection of things that Noreen mentioned as well. So that's my first point. As a medical professional, it's very easy to miss addiction and to go for short-term solutions that are just catastrophic in the long term, and often those are prescribing solutions. And the other thing that I wanted to share with you was, it's actually a metaphor which a colleague of mine in Oxford shared with me at the time. And he said to me that he liked to think of his patients who were experiencing addiction and homelessness as participants in essentially some big game of snakes and ladders. And when he said this to me at the time, I found it quite flippant and a little bit insensitive. But since then, I've thought a bit more about it, and I see what he means, so I'm going to tell you. And I don't use the metaphor lightly. Patients who I've been very fond of have died in the process of this. And it's a cruel and harsh reality. So snakes and ladders, for those of you who don't know, it's a board game where you have to get from one side of the board, one corner of the board, to the other corner of the board, moving forward a step at a time with the roll of the dice. Okay? Just one by one. And so what are those steps in the real life game of snakes and ladders? Stable housing? And I don't just mean having accommodation. It's more than that. It's having accommodation that you are able to keep clean enough to live in. It's having accommodation where you have control over your own front door, where you're sober enough, with it enough, to be able to decide who you're going to let in and who you're not going to let in, because it can unravel very quickly. Managing basic finances, and that would be a big stepping stone. And that's really simple things again, like, do you know, paying the electricity bill. There's no use spending your money to stock the fridge up or the freezer up if the electricity cuts out, because that's a catastrophe, because you've lost everything. I've got a patient who ended up sleeping on the street because of exactly that sequence of events. Ran out of his electricity was cut, he lost the food in the freezer, other people came into the flat, and do you know, he's back on the pavement again. Building a social network, but not just a social network of friends who are drinking or using still, who will perhaps drag you back to where you were. And certainly not a social network which involves dealers who are very keen to be your very best friend as soon as you start recovering. And employment as well. Something to focus on, something to distract you, and something to feel proud of. And I suppose when I think about those steps on that board of snakes and ladders that I was looking at, what surprises me is how few of those steps centre around or revolve around medication. It's the bigger social things. Certainly some of them do, but not all of them. And what worries me is that the focus is disproportionately on those steps with the medication. The other side of the snakes and ladders is the ladders. And as you go and make your way step by step across the board, it's very easy to land on a snake. And when you do, you slither right the way back to square one. And in the real life version, that snake could be a poorly planned prison discharge. It could be an ill-judged decision to let your friend who's still using stay on your sofa overnight. It could be anything. But when it does, when people do slither right back to the beginning, it's so quick and so complete. And for them it must be crushing and demoralising. And I think that is the thing which I see as a common thread, is that process and that repeated slithering back to square one just wears people out. I think that it sort of erodes their hopes for the future, dissolves their ambitions and their dreams, and I think it takes the colour out of life, and I think it takes the direction out of life. And for me, I think that that's the real thing that we need to focus on, is trying to resolve that. And I don't think that a medication is the answer to that.
Wow, thank you.